Incontinence Institute webinar for continuing education on an urgent global topic, novel coronavirus, what nurses specialized in wound, ostomy, and continence need to know to be prepared. We have the pleasure of having with us tonight Dr. Lorne Wiesenfeld. Dr. Lorne Wiesenfeld undertook his medical undergraduate training at McGill University and graduated in 1992. He completed a residency in family medicine in 1994 at the Queen Elizabeth Hospital, McGill University, and continued his postgraduate medical training in emergency medicine with specialty certification by the Royal College of Physicians of Canada in 1997. Upon completion of his specialty training, Dr. Wiesenfeld served on staff at the McGill University Hospital Center's Department of Emergency Medicine at the Royal Victoria and Montreal General campuses. He was assistant professor and site director of education of the Royal Victoria Hospital's Emergency Department. In 2000, Dr. Wiesenfeld relocated to the University of Ottawa to join Canada's most productive emergency medicine academic team. He was residency director of the FRCPC Emergency Medicine Residency Training Program from 2001 to 2010, where he oversaw its growth from 5 residents to its current complement of 45. He is an attending staff at the Ottawa Hospital in the Department of Emergency Medicine. Dr. Wiesenfeld has spoken widely in the area of medical education and has published in this area. His areas of interest and expertise are in interdisciplinary collaborative practice and health advocacy. Dr. Wiesenfeld has been an invited speaker in these domains to both the French and English media. Dr. Wiesenfeld has served as Vice Dean of Postgraduate Medical Education since July 2013 at the University of Ottawa. This portfolio is responsible for the oversight of over 1,000 postgraduates spread out over 70 training programs. Current projects that he is working on include the creation of postgraduate training following Canadian standards of accreditation in Shanghai, China, as well as the expansion of Francophone training programs at the University of Ottawa to meet the needs of Ottawa's population. Dr. Wiesenfeld, thank you so much for your time this evening. Without further ado, I'm happy to pass over control to you.
Thank you very much for that introduction. And thank you everybody for chiming in tonight. And as well as thanks to NSWOC for inviting me to speak on this timely topic. You should have the presentation before you, Coronavirus 101. This really is, even for those of us who are on the front line, a 101 as well. Just a disclaimer, I am only funded by the University of Ottawa in my capacity as a postgraduate dean, as well as the Ministry of Health and Long-Term Care in Ontario as an attending physician in the emergency departments. I don't speak for any speakers bureaus or have any disclosures to make. So thank you very much, and we'll proceed. So the first thing is, just get the next slide. Thank you. So the first slide, so, okay, so coronavirus is something that it's obviously in the news of late. And one of the things is it's been around for a while. We talked about the novel coronavirus. What we by novel today is new. But coronavirus is endemic. It's present throughout the world. And about 1 in 6 to 1 in 7 of our common colds are actually due to a coronavirus. And that goes up to 1 in 3 during the peak cold season time. And that's probably just because of the proximity of people around, as well as the dry air, cold dry air, which is very helpful for the bacteria to spread. And most of the time when people get a coronavirus, it's usually mild. It doesn't cause anything more than some lower or upper respiratory tract infections. And anybody's susceptible, but tends to be seen more commonly in kids. And like any other infection, there's a small percentage to medium percentage who are infected but are asymptomatic. So bringing up some of the memories you might have from microbiology, it's a member of the family Coronaviridae. And you can tell that if you look at the little picture just beside of it, the buds around the virus resemble that accompany it look like a crown. And it's a single stranded RNA, and like any other virus, only way it can reproduce is by infecting cells and developing and reproducing within the cytoplasm before causing the cell death. The diagnosis is largely clinical. When you think of how many people come in with any type of virus, we don't test. The only really real way to be sure of it is by doing polymerase chain reaction, or PCR. And I'll get to that in a bit later in Canada, but a little bit later in the presentation. But in Canada, PCR is only reliably done for viruses like coronavirus in our national laboratory in Winnipeg. So obviously, everybody who wishes to see if they're tested for this virus or any other unusual virus is unfortunately going to be a bit disappointed in that they cannot get the results that they want, the test that they want, if they are not severely ill. Most coronaviruses do have a reservoir. They tend to be mammals such as bats or birds. They have a vector which comes to humans, and as long as we keep encroaching on areas of wildlife, we're going to be, and literally bringing down the trees, shaking the viruses out of the trees that are there. These viruses are going to come through animals which are coming in proximity or brought to our cities, our metropolises, and then eventually through to us, which we, because of modern transportation and as well as the ability to move from one place to another with relative ease compared to 50 years ago, obviously spread the risk of infection much more highly than it would have. Say the greatest infection when you think about recent memory or recent history, which would be the 1918 flu epidemic. Just a little bit more on the microbiology. There's 4 genera which in the coronavirus family, and 2 of them can affect the humans. And they're largely respiratory in how they affect us and their pathogenesis. There are occasional ones that can uncommonly cause such things as gastrointestinal disturbances, but for the most part, by and large, respiratory, and then go from there. And it's the beta coronavirus, which is the one that really has been causing us the most trouble. Most commonly is the coronavirus, this community-acquired respiratory one. So you'll see these abbreviations. There's SARS, which everybody remembers. If anybody's out there, just if you can hit the mute button, that'd be great. So going back to the slide, there's SARS, severe acute respiratory syndrome. And if you remember back in 2002, 2003, MERS, Middle Eastern respiratory syndrome, and of course, what we now call the coronavirus, but is really the 2019 novel coronavirus. And you'll see that abbreviation 2019-N.CoV, just so you'll recognize it when you see it. So the community-acquired one, when it gets to infants, it really causes maybe a little bit of reactive airway disease like a bronchiolitis or severe pneumonia, and maybe in older kids, some otitis or exacerbation of an already existing asthma condition. If it's bad enough in adults, which is not usual, pneumonia or exacerbations of their COPD that they have. And of course, with many other infections, the older or immunocompromised patients, it can really cause some serious lower respiratory tract infections. Normal incubation for this virus, the regular community virus, is only about 2 days, and it sheds for 3 or 4 days after you've been inoculated and exposed to it. So I'm bringing up just a few of the pandemics that hit us before. If you remember from SARS, and there's a photo of somebody back in Hong Kong who's being decontaminated. And those of us in Canada, particularly our colleagues in Toronto who lived through this, it was a very difficult days to be a healthcare provider as well as a family member of a healthcare provider. Incubation for that virus was only about 4 to 7 days, and the symptoms, like an influenza-like illness, cough, shortness of breath, and unlike what you would think were a respiratory viral condition, about a quarter of the patients developed diarrhea. The people who actually died of it, there was nobody under the age of 24 who died from SARS. But we do know that as age progressed, the population that was more affected, as well as their premorbid conditions, affected the severity of disease, as well as those patients who were pregnant. So like our the novel coronavirus, it started in, again, China, and it's thought to be from reservoirs that are supposed to be bats, is what they're thinking. And it went to the palm civet. And if any of you, just for a bit of useless trivia, that's the civet cat. That's the one where with the world's the transit for animal for the world's most expensive coffee bean. So feel free to Google that at your leisure, as well as the raccoon dog. So something happened. These animals were brought into brought into either into cities, into markets, and there was the virus, which is not easily able to jump from animal to human, was able to jump from animal to human, and then eventually from human to human. And that patient, index patient, was it who first became sick, went from Guangdong in the interior to Hong Kong, and that spread out to the world. And they were able to trace it back large of all the infections worldwide to that one patient in Hong Kong. Fortunately, there was a rapid response by the World Health Organization, though a somewhat muted initial response by the authorities in China at that point. And we have not seen SARS, at least on an international level, in over 15 years. It was spread by droplets. We thought maybe if it gets on fomites, and there are over 9,000 cases. And right now we have about 27,000 documented cases of novel coronavirus. And I say documented because there's probably a lot more people who have infection or been exposed, but have not been tested because they haven't either presented to physicians or they didn't meet the criteria to meet the threshold for being tested. Now, back with SARS, it spread about 29 countries. I mentioned almost 750, 775 deaths, and the mortality was in the teens for the most part. So our next one that came up in recent memory is MERS, so Middle Eastern Respiratory Syndrome, and first discovered in 2012 when a man died in Saudi Arabia of a massive pneumonia and acute renal failure. Fortunately, despite its mortality of 35%, again, older and patients with comorbid medical conditions, only about 858 died out of 2,494 for infect that we know of. Reservoir thought to be camels and originated in bat virus. So incubation for those, again, about 7 days, which on average, anywhere from 2 to 17 days. And the reason it spread easily until we figured out what was going on, I'd say collectively, is because we became lax. There was aerosolization of when somebody comes in with a respiratory illness. Of course, we treat them with aerosols of Ventolin and Atrovent and such. And we learned in SARS, and this was reinforced in MERS, that aerosolization, like giving somebody an aerosol treatment or trying to induce sputum cultures, is probably a fantastic way of getting the virus outside in your room where you are. We don't know how long it stays in the room as well. My own home, the emergency department, is notorious for nosocomial spread, the overcrowding, sometimes the rush of taking care of people, often leads to breaks in hand hygiene. So our topic at hand that brought us all here this evening is the novel coronavirus, and like many other, it originated in the interior of China, in the city of Wuhan. That's a city of about 11 million metropolitan, so it's bigger than any city in Canada, and I guess maybe only one of the top dozen large cities in China. And like MERS and like SARS, it's a beta coronavirus, and we think it came from that. And when you sequence the DNA from that, it looks like it came from the same animal market for all the cases. And that was the Wuhan Market. It was a seafood market, a live wet market. And probably the first cases, I think, were probably there in November, if not earlier, of 2019. And because of multiple reasons, which are only coming to light now, it only really came to light to the national Chinese authorities later on. And the WHO received an alert of a new type of pneumonia, which is affecting a lot of people, particularly those who work or have been visiting this market. The market was only closed on January 1st that year. And a week later, they were able to identify the coronavirus as this novel coronavirus as the etiology and the viral cause culprit of this. The first death only happened on January 11th, and it's to show how fast things spread. It was noted in Thailand 2 days later, as well as other countries. And what preceded was a massive quarantining of cities by the Chinese government. Wuhan was closed off the government, all but isolated, kind of rail, road, plane, as well as bus access. And now it's gone up to over 10 cities, affecting over 60 million people under quarantine. As when January 30th happened, and we're getting to 10,000 cases, over 16 airlines have cut off flights to China. And that's another 3 were added today. And the WHO declared a public health emergency. Not something that's taken quite lightly. So you can see from the map the countries where coronavirus has been confirmed. And I say confirmed, not just suspected. These are actual proving cases in a well-run lab. And if you're interested, there's a very interesting map. Just Google Johns Hopkins and coronavirus. And there's a live, up-to-date map of where all the viruses are in the world in terms of, all the cases of coronavirus have been documented. So this number, actually, I've had to update this already 4 times since the weekend. You can see I last updated an hour ago, and it's probably higher now. The reassuring, you can see how quickly it's spreading. Fortunately, the death rate, there's only 564, so it's only about a 2% death rate. That's not too, it's very unfortunate, obviously, for the patient. And when you get to numbers of hundreds of thousands or even a million, that's 20,000 deaths. Quite tragic, obviously, but not as high as, at least for the moment, that we're aware of. All the deaths right now have been a few days ago in the Philippines of a Chinese national who was in Wuhan, who took a flight to Philippines, where he subsequently diagnosed with the novel coronavirus and has since unfortunately died. So for those of you looking for up-to-date references, a good place to start are the CDC of the United States, as well as the, of course, Government of Canada, Public Health Canada. The CDC one is a little bit more granular, and it gives a little bit more detail. So it's a little bit easier to read through for those who wish to continue reading. The updates are changing every day, if not sooner than that. The CDC itself, which is a very functional branch of the United States health sector, Department of Health, they noticed that there was something going on, and they started setting up a management structure January 7th. And 2 weeks later, they saw their first case and activated an actual emergency operations center, recognizing early what was going on. And even less than a week later, level 3 advisory, meaning and a similar thing happened in Canada, avoid all unnecessary travel to China. And just at the end of the month, the White House banned all visitors from China, with the exception of Macau and Hong Kong, in an attempt to not just to stem the spread of the infection to the United States. As of February 5th, in the United States, PUI is persons under investigation. They had 11 people who tested positive, 206 are negative, and 76 are pending. You can see this all through the states. You have some in Massachusetts, Arizona, California, and Washington. So you have both coasts as well as the Southwest. So obviously it spreads quite easily. And just to show in Canada, we have not been spared easily as well. Our first case was in January 27th this year of somebody who came back and was presumably non-infectious on the flight. And just if I could put it in one comment, everybody's very harsh on throwing stones at he must have felt terrible on the flight. I don't know anybody who's come across an international flight and not felt unwell when they arrived, but presumably he was not feverish, and he also infected his wife. And in Canada now, we're up to 4 cases, potentially 5. We have 2 in Toronto, this original gentleman and his wife, a student in London, 1 confirmed in British Columbia, and there's a second one which might be confirmed, which is pending confirmation today. So small numbers, but we're still, I think, at the early part. There's really no vaccine, at least at this point. Flu vaccine will not protect against this. I implore everybody to get a flu vaccine unless you have a medical reason not to, particularly as healthcare providers. I think we do have a responsibility to particularly the vulnerable patients we treat, the populations. But the influenza virus, which is still beneficial, is not effective against this virus. And though people have tried various antiviral treatments, retroviral treatments, there's been really no specific treatment as of yet that can target the virus itself. The only treatment is supportive therapy, treat secondary conditions such as secondary infections, such as pneumonia that arrive, treat the acute renal failure, and ventilatory support, and most importantly, infection control. So how does it present? Well, most patients at the onset, one of their first symptoms is fever and a cough. And unlike, let's say, influenza, myalgia and fatigue are not present first initially at the start, which for those who've ever had influenza or taken care of patients with influenza, they'll know that the myalgia, fatigue, and the headache are really up front, right at the start. And these patients can be anywhere from asymptomatic to mild, just thinking it's just like a cold, like a sore throat, to severe or fatal disease. And again, a little bit of reassuring is the mortality is quite low. But we'll see how as time develops, if this is going to change or not. We know it's spread among close contacts, such as it's happened in Toronto, but at least at this point, the community at large in North America is not at risk. The incubation period is on average 5 days, but it's anywhere from 2 to 14 days. And there's, strangely enough, there have been reports, including the potential one in BC, that the people are able to infect others without having any symptoms. So that means either they're shedding virus in the incubation period, or they're shedding virus without ever having developed a clinical condition of even a mild cold. There's no data to support that yet, but it has been reported and something to keep an eye on. And how long are these patients infectious for? We don't know. We know that if you had SARS, you were considered infectious at least 10 days until after your fever had ended, and as well as assuming you had an improvement of your respiratory conditions. But again, we don't know how long somebody will be infectious for. To show how severe it is, though, then those patients who get hospitalized, and you must remember the vast majority of these are in China, so there's different admission criteria to different units in different places. In my hospital in Ottawa, to get admitted to the intensive care unit, you probably need to be on vasopressors and or require mechanical ventilation. Those smaller hospitals in my area, you do not need all those conditions. However, when you look at it, almost a quarter of the patients who require hospitalization for coronavirus, they end up with acute respiratory distress syndrome. We're getting a little bit of feedback there. Don't forget to mute. And as well as need mechanical ventilation in a subset of those. Obviously, the mortality is a lot higher in your hospitalized patients, like any other viral illness, which is can be quite aggressive. You get associated acute kidney injuries and probably myocardial injury secondary to type 2 MI, so stress on the myocardium in the absence of any significant or symptomatic coronary artery disease. So when the CDC asks, should we be worried? Their answer is pretty sensible. Outbreaks of any new infection, really, we should really be careful. And particularly as healthcare providers, and we have to say also the families around us, we know that more exposure probably means greater risk. The United States, just to show you, it's very hard to stop international travel. Before the planes were, before White House and the President of the United States ceased flights between the United States and China, there are 14,000 people who travel between China and the United States every day. So that's quite difficult to turn that tap off. What Americans are asking, CDC is asking about questions of respiratory tract infection. Having been in mainland China, if you can put on mute, mainland China less than 14 days ago, or close contact with somebody who's had the coronavirus and it's confirmed by laboratory testing. And it's always tricky for healthcare providers like ourselves. What does close contact mean? Well, the United CDC said initially, and this just changed over the weekend, this is the old definition, being less than 2 meters, so 6 feet for a prolonged period. And they don't really define prolonged period of time. So is that 5 minutes? Is that 2 hours? It's not known. And it's being in presence of them without wearing any protective PPE. And that includes everybody, caregivers, if you're just sharing a waiting room with them while waiting to see their family doctor or in an emergency department, or if contact with an infectious secretions of the virus while not wearing PPE. So it would be family members or healthcare centers where infection control risks are not sufficiently mitigated. They've now made it a little bit more granular, and this is something worth reading. And they say those who are at high risk are if you're in the same house or an intimate partner or providing care in a non-healthcare setting, so a home or or a daycare, where there's a confirmed coronavirus patient, and that patient has had travel from the Hubei province, where Wuhan is located. They put it as medium risk with those other forms of close contact we talked about, such as being also less than 2 meters on a plane, being in the same household as somebody has confirmed diagnosis, but you are using the recommended precautions as instructed to you by the healthcare and infection control authorities and experts, and you're diligently using them. Or travel in China, but not to Hubei province, and you have no other high-risk features. And low risk would be being in the same indoor environment with a patient for a prolonged period of time. Again, no definition. Or you're more than 2 meters away on an aircraft. But it always makes me think, so if you're on an aircraft, I don't know anybody who's on a 12-hour or 14-hour flight without at least getting up once to go to the bathroom or something like. But at this point, that's considered low risk. But I guess not much comfort to somebody who's even 18 rows back. The concern is there. So a patient calls up to your clinic or calls or it says they're on the way in, and what should you instruct them before they even come in? Well, first, ideally, you should have a room where they can go, a private room. Unlikely any of us can get an airborne infection isolation room easily. Even in emergency department, we have a few rooms. What do? Tell them to wait in their vehicle until they can come in, or even wait outside. If there's nobody else, if they stand more than 2 meters away from somebody else, give them a surgical mask. That should be sufficient for that point. And the surgical mask is one of those points of contention. It has to be something that's changed frequently, not moist. And what are they doing? Is stopping massive droplet spread. You as a healthcare provider, you should be getting at that point within standard and airborne precautions ready. And don't forget your eye protection, so an eye shield or closing goggles. And when the patient gets admitted or comes into your center, they have to reinforcement of a very diligent hand hygiene, explaining respiratory hygiene and cough etiquette, coughing in your elbow sleeve, of course. Distressing the family. You have to minimize visitors. Doesn't mean no visitors, but it's the more people come in, the more likely they're going to break infection control. And it's very important to have those visual reminders telling us in our busy environments where we all work, wherever we work, that to be aware of the patients who are at risk to other populations or environment. It's also important that we use dedicated or disposable non-critical patient care equipment. So BP cuffs should be just for that patient, for example. And cleaning and disinfecting as per what the manufacturer says for that equipment. No sharing of equipment if you can do it, keeping patients isolated. What about ourselves? It's diligent hand hygiene. That involves hand hygiene before we come in the room, before donning our disposable gowns. Regular gloves are fine. We need a fit tested N95. And I just, for all these years, I've been thinking N95. Probably a few of you knew this, so you're ahead of me on this. But N95 I thought was proprietary, and when I looked at it, actually means screening out 95% of particles. So there's even an N99, and of course a 99.999, which is they call 100. You shouldn't, the guidelines are you should not be taking care of these patients unless critical without an N95 mask that you've been fit tested for. There have been some literature which has shown that an N95 may not have been necessary in SARS, maybe in other coronavirus infections, but I'm present in guidelines and directives from every health authority I read that I've encountered, as well as in my own hospital, as well as my own family, would be you wear an N95. Is a surgical mask good enough as a healthcare provider? Maybe, but it should only be used as a last resort if the patient's an extremist and there's nothing else. Otherwise, though, it should be an N95. And again, I can't stress the eye protection, critical, and avoiding doing anything that might aerosolize what's in their lungs or in their mouth by such as salbutamol or ipratropium treatments or inducing sputum, unless unless you have full precautions. And definitely no aerosolization in a non-airborne negative pressure in a negative pressure room. So what about in Canada? Talked about the CDC for a bit. Canada says avoid all non-essential travel to China and avoid all travel to those areas around. And it's not just that. It's not because it's infection, but they also, it's a highlight, just it's difficult to get transport in or out from a practical point of view. And the screen they recommend is if you've had a fever or an acute respiratory illness and recent travel to Hubei province within the last 2 weeks before getting sick, or been in close contact with somebody who was ill and was recently in Hubei province. And there is a poster that's put out by a Public Health Agency of Canada. It's available, and I put it up there. Just for if you have a clinic where you're seeing patients, it would be a good idea to have like this or something else that's up there. I do like it. I said, if you have traveled to Wuhan and visited a live animal market, had contact with live or dead animals or a sick person, one of the CDC sites says, if you've been in contact with animal droppings, and I pretty much do not need to be told to avoid being in contact with animal droppings. It's something I try to do on a daily basis. So I suggest everybody do the same. So the Public Health Agency Canada puts as they define them into probable cases. So you've had a fever documented and a cough or a worsen of a cough, if you have let's say if you're COPD, and you meet all the exposure criteria as listed below, and you have a laboratory test which is inconclusive or unavailable, or it's deemed positive, but not by our national lab. So I live in Ontario. We have the Public Health Agency of Ontario. There is a lab. They can say if it's initially probably positive or not. However, all samples, at least at this point, must be sent to the National Microbiology Laboratory in Winnipeg to be certain. And the criteria are very similar to the ones I explained to on the other page. So we talk about clinical being diagnosed, being presumed and confirmed, and it's the same done by PCR. So many of you are supervisors, your professors, your instructors, mentors. It's what do you do in your own environment with your trainees? This has been a bit of a concern for us, and so we have how should I say, a group of all the healthcare trainees in Eastern Ontario, everything southeast of Pembroke and east of Kingston, and we've decided that for safety, and there's no literature support, this is just for practicalities, people as trainees at the student level, no contact with presumed or confirmed coronavirus. The reason is we thought the risk is too high, and it's not critical in terms of staffing that we have these people. These are students, they're not employees. And health providers, if I can extend to all, don't just mean physiotherapy students, paramedics, but also all those who come to your center. We have MBA students who come to Ottawa, our hospitals, but obviously not taking care of patients, but they might be in close proximity. We have engineering students. We have all sorts. We have physicist students training in nuclear medicine. So we have shut them out should they have any risk of being exposed to coronavirus or a possible confirmed case. For residents and fellows, it's a little bit more difficult. One, these are employees of hospitals, and they're employees like nurses. So the requirement is if they are in N95 tested within the last 2 years and their most responsible physician, meaning their attending staff, is in agreement, they can care for patients with coronavirus. And again, that's important because our trainees some of our graduate trainees will be our staff next year, and they do have to learn how to care for these patients. And also as employees of hospitals, we are all exposed, nurses, physicians, PSWs, everybody, we're exposed to infectious conditions, and we have to be careful. So for your own, just for your own familiarity here, there's a little checklist that's from the CDC. It's if you're not sure where to start, I suggest you check the Government Canada, the Public Health Agency of Canada website. Also, another site to check is IPAC, Infection Prevention Canada. They have some very, very helpful information. I strongly suggest if you have if you have an interest or concern, visit these sites frequently. They do change every couple of days, if not sooner. So I thank everybody for their attention, and I am open to questions, and I welcome them. So thank you very much.
So at this time, if you do have a question, you can click on the raise hand button just on the participant screen. There's a button at the bottom of the participant list. Once that's there, we can call upon you and be able to ask a question. Just going to leave it open for a couple more seconds there just to make sure we have everybody given the opportunity.
I have a question, Troy. It's Kim LeBlanc.
Please go ahead.
So my question for Dr. Wiesenfeld is, what do I do if I think that I've come in contact with someone who may have, been exposed, and then I myself start feeling ill? Should I self-quarantine? Should I go to the hospital? What should I do?
Okay, well, thank you for your question. So the first is if you encounter a patient, the first thing is to protect yourself and to protect the people around. So as mentioned, surgical masks at the very least should not be too far, ideally N95. If the patient is mildly unwell, well, even before they come in contact with you, you want to prepare your office. If they're mildly unwell, again, isolate them, keep them in a room. If they're coming to hospital, let's say they call your clinic and they wish to come to hospital, they're on their way to hospital, they should advise when they call for paramedics 911 that they think they might have this contagious condition. So not just the hospital be prepared, but as well as our colleagues in paramedicine will be prepared. As for yourself, the most important thing is if you think you've been exposed to it and you're now contagious, you're starting to feel symptoms, first thing you should do is if you're an extremist and you're having difficulty breathing, then of course call 911 or have somebody call 911 to bring you to the hospital with what I mentioned earlier. Quarantine yourself when you're hypoxic probably is not very conducive to getting better. If you do think you have a mild, if it's a mild case, again, so just like if you had any other infectious condition, even if this was a regular rhinovirus, if you're febrile and feeling unwell, you should quarantine yourself. Get in contact with your family doctor, or you can also, for those of you who work in the hospitals, you can also alternately try with your occupational health department. And depending on where you live, you can in Ontario, you can call the medical officer health number, but that will vary from province to province. But the most important thing is, of course, is not to spread the infection, with the sole caveat of if you are an extremist, do go to hospital, but forewarn so that they know what is coming and they can best prepare for your arrival.
Great. So again, if you have a question, please click on the raise hand button at the bottom of the participants tab. If you do have a question, I see we have Deborah Johnson here in the chat, just had another question here. Dr. Wiesenfeld, do we know how long the virus can live on an inanimate object? Thinking about not just the hospital environment, but also places such as subways, etc.
I don't think we have an answer for that. It's not as contagious as, like, the most contagious virus that I can think of is actually measles virus, but we don't know how that is, how long it'll stay as on a fomite. I wish I had an answer for you on that. All I can say is frequent hand washing, and in terms of somebody coughing and put on a handrail on the subway or on a table, it's very difficult to say. I don't wish to cause hysteria, but we just don't have any data on that. I'd just say always be careful and always try to practice good hand hygiene.
Thank you. So again, if you'd like to ask a question like Deborah just through the chat, feel free to type your message out there and I can read it out loud. Otherwise, click on the raise hand button in the participants tab. I'll just keep it open for a couple more seconds here to make sure we've given everybody the chance to ask a question. Okay, great. Well, seeing no others, I just want to thank you one more time again, Dr. Wiesenfeld, for everything you've done today. I think that was a great webinar and obviously very topical. So thank you on such short notice to be able to get out here and be able to present this in front of all of our NSWOCs and other invited guests.
Well, thank you very much, and I really feel honored to have been asked, and I'm very, very pleased and honored that people have signed up in their evening time, their free time. Obviously, it's a testament to my colleagues who are listening to give up their free time for the health of the people they take care of and the community they serve. So thank you again.
Great, and thank you, just to echo that, thank you to all of our guests who came today. If you came in late or if you want to be able to watch this webinar again, we are going to be posting the recording on our Nurses Specialized in Wound Ostomy Incontinence Canada website. That's going to be at www.nswoc.ca under education in our webinar series section. Thank you so much, everybody, and have a great evening.
Thank you. Oh, that wasn't too bad.